seconds. Okay, and we are live. Hello, web shadowers, and thank you all for attending our session this evening. Today, we're honored to host Dr. Hamilton, who will be teaching us about radiology. As always, please remember that the Google form will be posted in the chat box and in the description at the end of the video. With that being said, Dr. Hamilton, you may start whenever you're ready.
Okay, and just to check, you can still hear me, yeah?
Yes, okay. Sound is good.
Perfect. So welcome everybody. It's my pleasure to introduce you to radiology. And although I'm a diagnostic radiologist, I'm going to be focusing on interventional radiology. So hopefully that'll be interesting to you today. I am the chief of IR at my institution, which is in Palm Springs. It's this little desert town outside of Los Angeles. And I've been practicing here for 7 years. So if you have any questions, feel free to enter those in the chat and I'll do my best to answer those. But I do have some cases to share today. This could be a little bit interactive, but if most of you are pre-med, I wouldn't expect you to know a lot of this stuff. So just try to take it in and, feel free to ask any questions. Like I said, on Instagram, I'm at Tired Superheroine. So in my world, tired can be a good thing. Let's see. This first image is me in the interventional suite with one of my assistants. So in interventional radiology, it's a lot like an operating room environment. And can you see my arrow if I point?
Yes.
Okay, great. This is actually the patient line here. The patient's head is up here under the drape, over here, sorry. And patient is laying on this table, and this kind of disc hovering over them is called an image intensifier. And that is part of the equipment that allows me to do live X-ray while I work. And that allows for image guidance during a number of different procedures, like in the blood vessels and in the organs. So you can see it's a sort of sterile atmosphere. I have this table with all my equipment back here. And since we're doing image guided procedures, you can see that there are some screens involved. It's sort of like video games when you're working sometimes. So I have this large screen. It's kind of like a big flat screen TV. And you can see in the distance, this is like a patient's heart and this is their chest. And so I'm putting in a dialysis catheter. And here, the smaller screen is an ultrasound unit. And I use ultrasound to get access into the blood vessels. And once we have access into the blood vessels, we can do lots of different things. I didn't realize this is a little bit blurry. Anyway, ignore that. Here we have, so I'm numbing the patient up to put in a dialysis catheter. And that catheter is a plastic tube. It'll go into their jugular vein over the collarbone. And it will terminate in the right side of the heart, which is like one of the biggest venous spaces in the body. And then in that location, through the dialysis catheter, the patient can get their blood cleaned by a dialysis machine. So I'm basically giving them access for dialysis here. So aside from dialysis access, what does an interventional radiologist do? Well, we do a lot of image-guided therapies for a number of different things. So just to give you in broad strokes, I treat things like infection, whether it's in pre or post surgery, arterial pathology, like when there's bleeding or aneurysms, venous disease, when people have varicose veins or clots in the veins or the veins shut down. Cancer, I have minimally invasive therapies that I do for cancer, and trauma, which is what I'm going to focus on today. So I have some cases to show you, and feel free to just jump in if something's not really clear, but I'll do my best here. Basically, radiology is a 5-year residency total. So you do a one-year internship after medical school, and you can do that in medicine or surgery, or a mixed year, which is what I did, called a transitional year. Then you do 4 years dedicated imaging from head to toe. And what I did was an extra fellowship, 1 year of interventional radiology. So for a total of 6 years. So there are different branches of radiology, but we all have this common thread where we understand images. And so these are some of the images we're going to start off with here. This was an unfortunate case of a 19-year-old lady who stabbed herself in the chest. And we are looking at the patient's chest and slicing this way, if you can see me. These are called axial images. So we are looking at different levels of her body. You can see this is the front of the patient and this is the back. So here's part of her spine. These are the great vessels. So the aorta, oops, I didn't mean to click, and the main pulmonary artery. And this is her sternum, which is a bone. So you can see dense things are bright and dark things like air in front of her or air in her lungs are dark. And then we have some contrast going through her blood vessels. So here, you will learn in anatomy once you get to medical school, or if you take it in college, that there's not usually a whole lot of space between the great vessels and the sternum. There's just a little fat pad, and the fact that all this bright stuff is here is abnormal, and that is from the stab wound. So I think you see it better on this image, the second one, where you see these little bright dots on either side of the sternum. Those are the internal mammary artery. So when she hit herself, she actually damaged this left internal mammary artery. And you can see there's a very subtle asymmetry here. So if you look from side to side, these are at two different levels. Like I mentioned, this is higher, this is lower. You can see more of the heart on this image. You can see here that that bright dot is almost completely missing. So for me as an interventional radiologist, I'm thinking, did she transect the artery? Did the knife completely go through the artery? Or it could be spasm. The artery has a muscular wall, and so it can react by spazzing down. And so the surgeons came to me and asked for my help with this case, so they wouldn't need to actually open the girl's chest and physically ligate or tie off the artery. And this is what that looks like. So using ultrasound, I get into the artery in her thigh, which is called the common femoral artery. And this is the live X-ray guidance that we use. And this line is a skinny plastic tube called a catheter. And this is a microcatheter. So using these tools, using a tube and a wire, I can drive through the body under X-ray guidance and get access into this left internal mammary artery that I saw that was damaged. So here you can see I'm on, this is a subtle area of spasm. So she didn't completely transect the artery, but it was, there was an area of spasm where there was bleeding, which is a common reaction when arteries are bleeding. What I did here is you can see there's a little coil pack. So I can, through this microcatheter that you see here, which is like a little, angel hair, or a little bit thinner than angel hair. Basically, that's what I'm guiding through the patient. And through that little piece of angel hair, there's a hollow bore, and you can deploy this little coil. And so I was able to treat that vessel injury using two little coil packs here, proximal and distal, so on each side of the vessel injury. So that's an example of a minimally invasive procedure for trauma. This is another example. This was a 69-year-old man who fell from a ladder. So sometimes our trauma patients are young and healthy, other times not so much. So here we have another CT image again. So computed tomography is a CAT scan. And this is with IV contrast. You can tell because the vessels are lighting up here. The reason we do that in trauma patients in particular, contrast helps us with to diagnose a lot of different things in radiology, but in particular in the trauma setting, we want to see whether there's any active leakage of the contrast from the blood vessels, which is what you can see here. So in the left hemipelvis, so in radiology, everything is flipped. It's kind of like you're looking at the patient. This is an image down at the level of the hip joints. So this is pretty low down in the pelvis, almost behind the pubic symphysis. And you can see this is an abnormal collection, which you would learn in radiology residency. It's a hematoma. And this is the arterial phase. These are the femoral arteries lighting up. And here you can see that there's active extravasation. So this irregular bright thing in the middle of the hematoma means that he is actively bleeding into that area. So his blood pressure, I just gave you some of his vital signs here to show. So normal blood pressure is classically like 120/80. And when you have a trauma patient who's bleeding, their blood pressure can drop, and compensatorily, their heart rate can increase. So this gentleman had a low blood pressure of 86/56, but his heart rate was still kind of a steady 72, so within normal range. So this is his angiogram. You can see over here, this is my device. You can see a shadow of my sheath, which is a plastic tube that I work through, is going into the right thigh artery or the common femoral artery. So this is a pelvic angiogram. This is a subtracted, this is a live x-ray image showing just the contrast. So it's a subtracted image, and that gives you this beautiful image of the blood vessels when you're looking under x-ray. Here you can see, looks like the blood vessels, they're not symmetric. So this is the aorta up here, and it's splitting into the iliac arteries. And you can start to see, even on this early phase of the image, there's a little blush right there. And with practice, as a radiologist, you would know that corresponds to the area on the CAT scan. That's where he's actively bleeding. So this is the next phase of the angiogram. So it's filming, as the contrast is washing through the blood vessels, and you can see, so the vessels are starting to wash out up here. It's still a little bit darker down here, and you can see where this blood vessel is perhaps supplying that area of extravasation. So now it's my job to navigate over there. And so that's what I did next. Using a special combination of wires, I had to go over this sharp turn. So he's got some tortuous vessels from having high blood pressure for many years. And I used a special combination of wires and tubes, those catheters, to drive into this blood vessel. And you can see when I selectively inject the contrast into that vessel, I confirm that that's where the active bleeding is happening. So as you can tell, this process of the angiography is both diagnostic and it can be therapeutic as well. So obviously my next step is going to be, we're going to stop this man from bleeding. And that's what we see here. So this is a 5 French catheter. So there are different size catheters, and 5 French is a really common size. So you can kind of see that relationship. It's big enough to see on the x-ray, but small enough to navigate even into some pretty small arteries. And then I put another catheter through that artery so I can go even further into these teeny tiny arteries. And again, just like that last girl that we embolized. So embolization is the process of blocking off these blood vessels that are bleeding. So I put this little crumpled metal material. I was able to push that through the little piece of spaghetti and block off the blood vessel that was bleeding. So we sacrificed that vessel. Okay, and this blob here is the extravasated contrast. So that's sitting in a pool of the patient's blood. And then once we inject after the embolization, you can see that he's not bleeding anymore. It's pretty awesome. And sometimes you can even see the patient's vital signs improve right on the table. The other interesting thing about this image is you can see what a hematoma does. So on x-ray, we can't actually see the hematoma like we could on the CAT scan, but here you can infer this is actually the bladder. You can see a Foley catheter balloon, which is this round thing, and it's in the patient's bladder, and the bladder is pushed off to the right by the hematoma. So you can kind of see things even in relief. It's pretty cool. All right, this is my next case. Let me know how we're doing on time if I start to go over. So with trauma patients, sometimes you're doing these really quick bedside interventions. Not everybody has the benefit of doing image-guided interventions like I do. So this was actually an unfortunate case where this gentleman, 61 years old, got into a motorcycle crash, had a small pneumothorax, which is a lung collapse. And the surgeons put this chest tube, and they use anatomic landmarks to get it into the chest, but this chest tube ended up in the liver. So this is a complication, and this is a problem because the liver has a lot of blood vessels which can bleed. So the surgeons called and asked for my help. As you can start to see, we work together a lot. So we kind of work hand in hand. You know, I'm not a trauma surgeon, but I work with trauma surgeons closely. Okay. And so this was a great example of how we can coordinate teams together in medicine to take the best care of the patient. So what I did was I put a catheter, again, from the patient's right groin down here, and you can see my little catheter. I got up into the celiac axis, which is the vessel trunk arising from the aorta that supplies the liver, spleen, and the stomach, among a couple other things like the diaphragms, usually in most people. So one of the joys of interventional radiology is you see a range of anatomic variants. So you can learn what normal is, and then you'll surely see everything else as well. But this is pretty, you know, I think he had pretty classic anatomy in any case, but just as an aside. So what you're seeing here in this middle image is a hepatic arteriogram. So you're seeing the arteries that supply the liver. And in particular, my catheter, you can see it's just over into the right hepatic artery, which supplies this bigger right lobe of the liver. This is the left hepatic artery over here, which is in the, you know, below the breastbone. What we did is I was able to do an angiogram confirming, you can see the chest tube is here, that I didn't see any problem with the artery. So I was looking for something like a pseudoaneurysm, if the artery had like an abnormal outpouching, or if I saw frank extravasation on the arteriogram, that's something I was prepared to deal with. And so while I had this image, I didn't see any problem with the arteries. Again, the liver still gets 2/3 of its blood supply from the portal vein. So there's always a chance that this tube could be in a portal branch, and that would also be a problem. But that's not so simple. So what we were trying to target was an arterial injury. So with my catheter still in place in the liver, the surgeons removed the chest tube, and I repeated the angiogram to make sure that we still didn't have any active bleeding and that we didn't have any vessel injury to take care of. And this is a nice controlled way to take care of this complication. I hope that makes sense so far. I don't see anything in the chat, so just let me know. If anybody has a question. Okay. So this next patient had multiple rib fractures on the left side, and you can see that there is some fluid. This gray stuff is fluid compressing the lung. So this is enhancing lung parenchyma that's smushed by the fluid, presumably blood from the rib fractures. And this, you can see this brighter stuff here is active extravasation of contrast. So this patient is actively bleeding into the chest. The chest happens to be one of these areas where it's very difficult to control the bleeding because it's not in any specific compartment. I mean, the chest can fill with a lot of blood before, you know, endangering the patient's life, before any tamponade effect or any, you know, kind of pressure buildup happens. So the trauma surgeons brought this to me and they said, can you help with this? And so what I did, it was another angiogram. From the groin, I went in, these are called the intercostal arteries. So under each one of your ribs, you have these little squiggly arteries, and they are closer to the underside of the rib, but as you can see, they're pretty circuitous. And so using the rib fractures as a guide here, this is very hard to see on this particular image, but suffice it to say, I counted where the rib fracture lied, and I was able to use that as a roadmap to see which vessel I needed to target on the angiogram. And so I didn't see any active extravasation, but it's actually okay to sacrifice these vessels. So here you can see I used, this is actually called a reverse curve catheter. So we have catheters with different shapes to accomplish different vessel access points. And so here you can see this catheter has a reverse curve. I believe this was a Simmons catheter. And then this thinner line is a microcatheter once again. So just to get purchase into the artery. And here I'm deploying some coils, and I also put some surgical gelatin foam into the artery. And so this patient did well. Okay, and I do see a question. So how are you able to maneuver the catheter? Great question. So under live X-ray guidance, these some of the wires can have a little shapeable tip. So and the catheters have shapes, as I just mentioned. And that combination of shapes means that you can turn the catheter to navigate where you want to go. And so the safe way to do this is over a wire. And then you select the blood vessel by pulling the catheter down, injecting little bits of contrast. And that's how I would get access into one of these vessels that I'm mentioning. The risk of any time you work in the blood vessels, there's a risk of, lifting up the wall of the artery. That's why this takes a lot of training to do. There's a risk of dissecting the vessel or damaging or knocking off plaque. So there are lots of, this is not without risk, but that's how we safely navigate through, is with some of those techniques that you learn. Okay, and good question. So what is the coil? The coils are often made with platinum, and they can be made with nitinol as well. So these are non-allergenic, they're inert metals, which just can kind of crumple or coil depending on the design of the coil. And they crumple into the blood vessel, and they kind of clog it like a clogged drain. Imagine you had a mass of hair or like pet hair in the drain. That's what this coil is doing. Coiling also depends on the patient's own blood to clot. So the coil makes like a framework, and even if you have like a crumpled mass, you could still have bleeding beyond the coil. So it does, the patient's own capacity to clot around the coils is also an important part of that mechanism. And then basically between the coils, like I mentioned, gel foam, that's a nice quick way. Gel foam actually recanalizes over time. So that's a good method to use if you want the vessel to reopen after the injury is healed. And then once the vessel is clotted off, you're not going to have any more bleeding. And okay, good question about general anesthesia. So these are done with moderate sedation. So that means if the patient is NPO, if they haven't had anything to eat for 6 hours, then I can give a combination of 2 strong medicines to give them like a twilight sedation. That means that they're awake and talking to us, but they are relaxed. And so as you might imagine, the access into the blood vessel, it involves some local anesthetic. So you feel a pinch and a burn as I'm getting access. And then after that, once the access point is there, this is not a painful procedure. So the patient can just lie there and just take a nap if they're tired, or, so we titrate that sedation to their individual needs. So, some patients are more anxious. They might need an additional dose of the anxiety medicine, and other patients may just have more pain. So we can target the pain that they're feeling and focus more on that part. If the patient takes a lot of medications, like if they're on chronic pain medications or anxiety medications at home, then we start to be able to need more sedation medications to sedate them. But I guess it's a whole other talk potentially. So, and then yes, local anesthesia for everything as well. So in conjunction. And how can you control where the wires go with such great detail and sharp turns? Yeah, so it's super fun and it can be a challenge, and a few different ways. And so you're using your knowledge of anatomy and you're using the equipment. So part of your training in doing this kind of work, which is work inside the blood vessels or endovascular work, part of the learning curve of that is learning the different properties of your tools. So some catheters are purposefully more stiff, or some are braided, or some are softer, some are tapered. So this is all like Interventional Radiology 101, and that I definitely recommend if you're interested in this, if you're going to do some real shadowing, not just web shadowing, then, just open up the first chapter of that interventional radiology book. I like IR requisites, or there's also like a pocket book, which is like a fat book, but it's, I believe it's an Indian name is the author. I'm sorry, I don't have it off the top of my head, but they go over some of this equipment and just the basics that you'll see again and again and again. And if you're going to shadow, it's really useful to just know a couple things. And then that will be the basis for learning additional tools. So it's a very specialized toolbox, and that's kind of the long and short answer. The other answer is practice. And so with practice, you realize okay, I have a catheter that's shaped like this, and maybe it's not giving me secure access into the blood vessel I need. So I may need to go to a reverse curve catheter like you see on this screen, which is called a Simmons or a Chung or some other catheter, or a Mickelson. So those are some of these catheters are all named after people. And yeah, so maybe one of you will have your own catheter named after you one day. Okay, this is my next exciting case. So these are kind of like my more dramatic cases, but I just realized when I came out into the community, I basically became a trauma specialist. So this was a 17-year-old male who, the other thing I love about traumas is every trauma has a story. So this was a guy, he heard his brother fighting with the neighbor outside, and he got shot in the groin 2 or 3 times. So really frightening, because as my team and I were rushing to help this person, there were also threats from this. I think there was some gang activity that somebody might try to come in and finish the job to this guy. So kind of stressful. But this kind of work really lends itself to if you handle stress well, if you are a little bit of an adrenaline junkie, the surgical procedures, the surgical fields may be for you, because you really have to act on the fly, and you have to, when there's an emergency like this, you just have to get calm, and you just have to focus on what your job is. And that becomes easier over time, of course. I think, once you get procedural experience, you realize okay, everybody else in the room has their job, and my job is to find the bleeding vessel and shut it down as fast as I can. And with that level of focus, it becomes a very, very straightforward. Here you see there is, okay, so this is through basically the base of the penis. And you can see that there are these little black foci everywhere. And that's not good. That's, that's air in the soft tissues, and that's where the bullet passed through. And here at the base of the penis, he has active extravasation there. So the surgeons had actually taken this young man to the operating room, and even the surgeons couldn't stop the guy from oozing. So they asked for my help. They said, "Can you please do something?" And he just wouldn't stop. They were packing. He kept oozing. Okay. And just for orientation, this is the Foley catheter within the penis here. So here you can see the corpora cavernosa, you can see the anatomy of the penis. Here's the urethra. So, it's, you can see all this anatomy here. Here are, the proximal femurs. Here are the femoral vessels. And this is the gluteal cleft, his rear end. So, and you can see there's just kind of bleeding onto the scanner, kind of a dramatic case. So this is an oblique image. So I can take that panel I showed you at the beginning that's over the patient, and I can angle it different ways to help me see where I'm going. And here you can also see my access sheath. So this is in the right common femoral artery. And this is an angiogram specifically of his left side. So in the left pelvis. And here you can see a relief image of the ballistic fragment. This is a bullet that's still in his part of his pelvis. And you can see this elongated spindly appearance of the arteries, which is from hemorrhagic shock. So he's just bleeding, and basically all the arteries are reacting by spazzing down. So they all have smooth muscle, and their reaction to bleeding, and especially when the patient's bleeding, in a life-threatening way, This is an appearance of shock physiology on an angiogram. So here's a more delayed image of that angio. And here you can see this is where he's extravasating out into the base of the penis. So normally there is a penile blush. And so we don't go around embolizing every time we see this. There is normally there's like a signature blush there that is normal. But in this gentleman, we know that this is not normal. This is from his gunshot injury. And I used gel foam to take care of that. So what that involves is in a syringe, I make like a slurry substance. We call it a slurry. So I take saline, contrast, and surgical gel foam, which looks like a sheet of styrofoam. And I can morselize that between two syringes and mash it up. And then I inject it into the artery and it stops him from bleeding. Then in 2 to 3 weeks, that gel foam will actually dissolve. And as his injuries start to heal, then, he'll have these arteries back that I've blocked off. Okay, and so here's his right side. Again, you can see this little blush here, and it's arising from the anterior division of the internal iliac artery. So these are the thigh arteries on the right side. And so these are the arteries going down the leg. This is my access point, and the arteries that are lit up are just supplying the inner pelvis, and this is supplying the buttock. So this is all this is all the anatomy that you're going to learn in anatomy over time. Okay, and so over the course of the angiogram, you can see that there's this active bleeding out. This is his sort of dilated scrotal soft tissues, and you can see that this is just contrast spilling out. This is abnormal. Okay, and here you see that bullet again. Okay, so here I have a quick quiz for you. I'm curious if anybody knows who pioneered angioplasty. Maybe you can answer in the comments or in the chat. Was it the vascular surgeons, the cardiologists, interventional radiologists, or urologists? So this surprises a lot of people, but interventional radiologists were actually the ones who pioneered angioplasty. And of course, it was adopted by many other physicians because it was a great technique. But it was the father of interventional radiology, Charles Daughter, who did the first angioplasty, and he saved a woman's leg. This woman was, she had gangrene and she was refusing an amputation, and he saved her foot. This is a pretty cool story. Okay, so this is a picture of him, and you can see he has a sort of crazy look in his eye. This is the father of interventional radiology, so Charles Daughter. And you can see these are actual images of the first angioplasty. He took that stenosis and he treated it with serial dilation and opened her artery again. So pretty amazing. So he actually did it with dilators, and nowadays we often do this with balloons. So you may have heard of an angioplasty balloon. Of course, I'm not featuring them in this talk on trauma, but they do have their place in trauma intervention as well. Okay. How are we doing on time? Okay, we're good. So this next gentleman was a 51-year-old male who fell asleep at the wheel. He was driving his new sports car. It was like an F-150 or something. Shattered his spleen. So these are axial images once again, slicing the body this way. And here on his right, you see the liver. Here on the left, you see the spleen. And all this fluid around the spleen is abnormal. And here you can see the splenic parenchyma is enhancing, and here you have a little cleft where it's not enhancing so well. That's the splenic injury. Here again, you can subtly see this kind of lack of enhancement in a linear irregular pattern. That's a splenic laceration. And here you can see a little dot that's super subtle, so don't worry if you don't see it, but it was, that's where there was active bleeding. So we went to angiography, and here you can see just how tortuous actually the splenic artery gets much more tortuous than this. So, but you can see that the catheter is coming up from the groin. It's going up into his upper abdomen. This is, just knowing your anatomy, this is the celiac axis, and then the splenic artery usually takes off to the left, unless you have some kind of a heterotopia. And so this is a selective angiogram of the spleen. And here you can see that there's active bleeding from that lower pole of the spleen. And on a later phase of the angiogram, you can just see it just pouring out into the perisplenic region. So very exciting when you see the problem, because then you can go out into the little splenic branch that is specifically supplying the bleeder, and you can just close that down selectively. And so that's what I did. I put another little noodle through this catheter that you see here. So you don't see the microcatheter in this image, but you can see my little coil pack that I left there. This is the contrast that extravasated out on the last run. And now you can see there's no more extravasation after I've blocked off that branch. So saving the spleen is one of the joys of being an interventional radiologist at a trauma center, because the spleen has really important immune function. We didn't always used to know this. We thought that we could just take out the spleen and it was no big deal. But later we found out that the spleen afforded protection against encapsulated organisms. And that's why people who have had a splenectomy, they need special vaccines like the pneumococcal vaccine. So if you can save someone's spleen by doing a minimally invasive procedure, it's really a huge win. This next case was another young person just minding their own business when they were stabbed in the back, and they were brought in by, I don't mean to laugh, you just get a sense of humor about these things sometimes because you just have to. So anyway, we helped this person, and it was like a 27-year-old stabbed in the back and wasn't feeling well. So they were brought in by their mom and their sibling, and their vital signs were compromised. I don't think you can see those here. Okay, but the vital signs were dropping. So what happens, the patient comes into the emergency room, they get some imaging, they get some fluids. So they resuscitate the patient a little bit. And we try to stabilize the blood pressure before they come to me and before they get on my table. And so that's what happened here. And here you can see, this is an image. You can see the stomach. I'm not sure, they must have had a huge glass of water. They had their Nalgene bottle, and they have a big air fluid level in the stomach here. And here you can see, this is their left kidney. This is the right kidney. And they were stabbed right here. You can see this bubble. That's a pseudoaneurysm. So the knife actually hit one of the vessels and damaged it bad enough so that it basically lacerated one of the walls of the artery, allowing it to bubble out. So this is like a contained rupture of the artery. And then here you can see the kidney is being pushed towards the patient's front of his body by this hematoma that's developing over here. And you can see these are his ribs. This is the lower part of the liver, just for reference. This is the aorta. This is probably the superior mesenteric artery here. Here you can see a little adrenal gland. So we're getting a little bit of radiology in. And this is the tip of the spleen. Okay. And okay, I feel like I left somebody behind. They said it's vague how you saved the 17-year-old boy. So the gentleman who was shot in the perineum, he was bleeding from the pelvic arteries. And so the way that you can deal with a lot of these different pelvic arterial injuries, so it's a common trauma problem. So some of these pelvic arteries are too small for the surgeons to actually control or find. And so I can go in with the angiogram and find exactly where it's bleeding. And if I don't have an exact location, I can inject that artery with gel foam, and the gel foam closes the vessel down temporarily. So like I said, then 2 to 3 weeks later, that gel foam will recanalize. So the artery will open back up as the patient starts to heal, but it will stabilize the patient and stop them from continuing to bleed. So I hope that makes more sense. Okay, and I'll just save some of these questions for the end. Okay, but I didn't want to leave that person behind. Okay, so back to our renal injury, so the kidney injury. This time you're looking at a CAT scan that is slicing the body this way. So this is actually like you have x-ray vision and you're looking straight through the person. So if you're looking at his abdomen, this is what you would see. You can see his diaphragm here on the right. You can see the liver with the hepatic vein. You can see his inferior vena cava. You can see his aorta with the 2 renal arteries coming off. So that's an interesting anatomic variant for this case. He doesn't have 1 kidney artery on each side. He has 2 on this side. So that came into play in this case. Here you see his stomach filled with fluid. You see that it's so much so that he has a little partial lung collapse here because he drank so much water. Here you can see parts of his colon. So this is actually stool in the abdomen. So a radiologist can really tell if you're FOS. We like to joke about that. And here are the hip joints over here. So I hope that gives you a little bit of reference. And this is an image on the right. This is an image further back. So you're looking, this is more of the front of the kidney, and this is more toward the back of the kidney where we see that pseudoaneurysm. We start to see the hematoma, and we also see the patient's spine. Okay, and you can see this is their descending colon. This is just full of poop. And these are the lovely things you get to know about people when you look at people's insides for a living. So this is an angiogram. So I took him to angio because, okay, what are this guy's options? Such a bad injury, he would lose this kidney if he went to the operating room. There's no way to just sew this up and repair it. So to save the kidney, so this guy doesn't end up, it's always nice to have an extra kidney if you can keep it. So we did the minimally invasive procedure. And here you can see I have access into the right renal artery. And just based on the CAT scan, I was suspicious that this would be supplied by the the more cranial of the 2 renal arteries based on the CAT scan. So the CAT scan was really helpful in planning the procedure because I knew, okay, he has 2 renal arteries on the right side, and one is more supplying the upper pole and one is supplying more of the lower pole of the kidney. And so I was pretty sure that the injury was going to pertain to the upper pole renal artery. So I was able to access that. And here you can see the pseudoaneurysm lighting up in the arterial phase. Here you can see some of the parenchymal blush of the kidney. Here's the outline of the kidney. And, here's a capsular branch coming over top of the kidney, and it's separated because there's that hematoma there in between. So that's actually the hematoma is prying apart. Normally this vessel would be right on the capsule of the kidney. So kind of interesting what you see in relief. And then the other problem that I see here is that there's an abnormal connection between the arteries and the veins. It's called a traumatic arteriovenous fistula. So what happened here is when the knife hit the kidney, it injured the artery and it communicated made an abnormal communication with the renal vein. And so you can see that this renal vein is lighting up at the same time as the artery, and that's not normal. So you can see the renal vein and the inferior vena cava are lighting up. So 2 problems. Okay, so I coiled off this branch. Again, if we have some collateral damage to the kidney, this is, we want to save his life first. And second of all, we want to save the kidney. So that's kind of our level of priorities. Doing this work will teach you priorities. And, so by doing this, I am permanently blocking off some of the blood supply to the middle of the kidney. And that's the price we pay for stopping the bleeding. So here you can see on the right side, I crumpled one of those little microcoils into this branch because I thought it was supplying the pseudoaneurysm. And I was right about that part. So you can see that in the second image, the pseudoaneurysm is no longer lighting up, but we still see this renal vein and the IVC filling too early. So we still have a traumatic arteriovenous fistula. So this can lead to all kinds of problems, from blood in the urine, which he surely had from this injury, but also things like heart failure. So if the artery and veins stay connected abnormally, it can actually lead to heart failure. So we don't want to leave that there. So I actually had to go in. So here you can see in better detail, this is my 5 French catheter and this is my microcatheter. So you can see you can use one within the other to access the smaller vessels. And that's where this abnormal communication was happening, through this other vessel that I found in the upper pole. And so once you shut that down with coils, you can see on this final angiogram that we don't see the renal vein any longer, and we don't see the IVC filling. And so we know that our job is done. This is also, this image is a nice example of vessel spasm. So here we've injected contrast, and the renal artery is an artery which is prone to spasm. So here you can see this kind of beaded appearance of the artery. And so, we have diseases that affect the renal artery and other arteries, but like fibromuscular dysplasia, FMD, this is not FMD. This is spasm. And we know that because it wasn't there before. So I'll show you that. See, the kidney artery is normal, and then you inject it again, and it starts to spasm. So that's okay. That'll go away with time. But just to show you a good example of arterial spasm that can simulate disease. Okay, that's it for cases for now. If you want to see, it's more high level. It was done for an interventional conference, but I do more trauma cases, more explanation, and that's on my YouTube channel. So if you just Google my name, Barbara Hamilton, MD, trauma in the community, then you can find that talk. If it's completely overwhelming, don't worry. That talk was written for interventional radiologists. So, it's kind of high level. I wanted to share this with you. I have a website and an audio that I recorded, and it's all about a number of failures that I endured on the way to becoming a physician leader in my community. And I just want to normalize the fact that failure can be part of the process. And so this was my way of doing that. So on my website, tiredsuperheroine.com, you can find this little set of over-ear headphones, and you can sign up to get that audio recording if you would like. And since then, I also started a podcast. So if you'd like to hear more about what it's like to be an interventional radiologist or a woman in a male-dominated field, that is a resource as well. It's called Save Lives, Enjoy Your Own. So thank you so much for having me. And then maybe I can tackle some of these questions, but I just wanted to make sure you had those resources. So on Instagram, please follow along with me. I talk about where IR meets life outside the hospital walls, and some advocacy and things like that at Tired Superheroine, and then my website, tiredsuperheroine.com. So I can just dive into these questions if that's what you want to do with the last 10 minutes. Okay. So please let me know. I hope I was able to answer that about the gentleman shot in the groin. So yeah, surgical gelatin foam, it's a magical substance. So basically we're talking about these trauma interventions. The bulk of them are called embolization. So embolization means taking an artery that's open or bleeding and blocking it off. And there are temporary ways to do that and permanent ways. And I showed you examples of both. So coils are a permanent way, and the surgical gelatin foam is a temporary way. Okay. So yes, when you're working with live X-ray and in general as a radiologist, it's really important to love your physics and your physics lab. And I'm totally kidding. I did not enjoy my physics lab. I was like, we had to drive little cars off the desk. I was like, what? I didn't get the calculations. So physics is important in this field because you need to understand how the X-rays are generated and how to protect yourself from them. So I think, it's something that kind of scares some people off, But if I can do it, I think, you probably can too. It's not easy to study radiation physics, but it's really important to the field. And so the ways that I use this in my everyday life are like, I know that if I bring that panel as close to the patient as possible, that's reducing the scatter radiation that comes to me. Or like an example of physics knowledge that helps me is knowing that the bulk of the radiation exposure that I could potentially get is actually, it's not coming from the machine itself, it's coming from the patient and bouncing out toward me. And so there are lots of ways to protect against that so that you don't get occupational radiation exposure. So it's really important you have that knowledge so that you know how to protect yourself. Of course, we all do standard things that, like, even if you forgot all your physics, you would still by and large be doing the right things because they're just habit in the interventional suite. But yes, as you become like the steward of radiation in your hospital as the radiologist. So if somebody tries to like order too many CAT scans on a young patient, that's like your job to say, okay, understanding radiation physics and the potential risks involved, is an important part of your job. How long does it take to obtain a good angiogram picture? So just the process of getting access to a certain vascular bed can be a lot of the work. So sometimes it's really easy and the catheter just pops in, and I might, say somebody's bleeding from their stomach or their small bowel. Maybe I'll be done with that procedure in 20 minutes. It can be really quick. But to get the actual, like a one angiogram, like I was showing you, that just takes, like 5 seconds or less. So we can, you're in control of that. And so it depends what you need to see. So the longer you have the angiogram running, the more radiation the patient is getting. But there are some reasons why you would want to do an extended angiogram. Like for instance, if you're doing an angiogram of the liver and you want to see if the portal vein is open, then you could shoot contrast into the celiac axis or the hepatic artery, and you could just carry that angiogram out for a few seconds until the portal vein lights up, because that's the way the blood is going to go that way, from the arteries to the veins. So I hope that wasn't too confusing of an answer. Okay, so I definitely do planned procedures as well. Like some examples of planned procedures are for chronic disease. So like I have cancer patients who come in, I can do procedures through the blood vessels for tumors. Sometimes I just stick a needle right into a tumor. I can fry it like right inside the patient's body with some sedation. That's called ablation. It sounds really close to embolization, but it's ablation. So thermal ablation, you can look that up if you're interested. And and then the dialysis work we do, so I'm seeing a combination of patients from outside the hospital, like relatively healthy patients who walk into the hospital who need something, and also hospitalized patients and emergencies. So all of these things are kind of put together in this lovely salad, which makes for a really fun variety and just like a really fun day. I mean, sometimes you don't really know what's coming through. You just do whatever comes through the door. And so that's something to consider if you like that kind of routine or not. So it's not always the most predictable, but I control which weeks I'm going to be on call. So I'm on call for a week at a time. And of being on call, I tend to get called in like once per week for something like a trauma. And it's not always as crazy of a case. It's, sometimes the patient is relatively stable, or actually during this past weekend, we had a full moon. So we actually had a couple crazy cases, and just being superstitious, it was like, is this the full moon? Is this Cheryl's last week on call? Like you want to blame something for these crazy cases coming in. But I had a crazy postpartum hemorrhage. This young lady, her uterus actually ruptured. And so the OBs, they rushed to sew it closed, but they were still worried. She had lost like 2 liters of blood. And so they asked me to do an embolization on top of that. Anyway, I'm going back to emergencies. So yes, the point is I do scheduled procedures as well. how often do I review anatomy? It's, as needed. So as an interventional or as a radiologist in general, you have CME credit that you need to do. So you're always kind of re-upping your learning. You're always, every year, you're going to seek out certain learning, whether it's online at a conference, and you're just going to continue learning. And then on a day-to-day basis, like if I see a patient, like a unusual vessel takeoff, I'll look that up. Or if there's a procedure I haven't done in a while, like I'll look up the cocktail of, drugs that I'm going to inject, or, there is the opportunity, of course, with reputable sources to basically lean on Google. Like I have gone to YouTube and actually looked at device videos to remind me, like, oh, how am I going to deploy this stent, or how am I going to do this atherectomy? So super cool time to be learning medicine, to be practicing medicine, because there's so much information available. You don't have to go rooting into a book, and actually, the books still have a lot of good information, a lot of basics, but there's so much adjunctive stuff these days. Do I review the anatomy before each surgery? Yes. So that's why pre-procedure planning usually involves some form of imaging. So you can see, like for these trauma cases, they're all getting run through the CT scanner. And that helps us to see, I can see the blood vessels. I can see, sometimes I can directly see which blood vessel is bleeding, and I know exactly where I'm going. Other times I'm like, okay, well, it's in this territory. And then when I get to the actual angiogram and I'm directly imaging the vessels, then I get a clearer picture. So yeah, the imaging is so key in planning. Oh yeah, my backstory. So I did medical school. I actually did a BSMD program. So if you want the lowdown on that, I have a dedicated blog post on that. So you can just go to my website and search for it, or you can Google Tired Superheroine BSMD program or BAMD program. That was a great experience and allowed me to save some money and a lot of interviewing, because trust me, you'll have plenty of interviewing later as you go from internship to residency to fellowship. So yeah, medical school. Okay, nobody wants to know about my internship. It was the best year. I went to Washington State, and I lived in Spokane, Washington for a year. So if you're a free agent, like I was at that time, you can just go anywhere and just move for a year. It's pretty cool. Residency was at Brown in Rhode Island, and fellowship was at UCLA in Los Angeles. And how do I deal with complications? Yeah, complications can be scary, and that's why medicine is a team sport. So sometimes I can deal with my own complications and I can actually fix them myself. There are times where I have called on my vascular surgery colleagues to come help me or give me an opinion, and we have a pretty good working relationship. I can't really think of a time where so occasionally, like, a complication will require an actual surgery, but it's almost like, it's so cooperative. You're handing off to each other. It's like where one person's skill set stops, the next person begins, and you're always discussing that. So you're, it's always multidisciplinary when you're a radiologist of any kind. I think it's very multidisciplinary, and you get to know all the different doctors in the hospital because you are talking about their options. So like, I might not know all the chemotherapy regimens for a given process, but I'm working with the oncologists to determine like what the best next step is for a patient. So the same goes with complications. And I think we're running out of time. So yeah, please, if you head over to my blog, I talk about a lot of my path and some more personal takes on like what it's like to learn to be a breadwinner of your family. Like, that's really important. And yeah, just how to navigate if you want to do like a surgically oriented or male dominated field. I like to talk about that because we need more women doing this work. And it's really fun, really gratifying. If you ever played video games as a kid and you want to do it as a grown-up, consider joining me. There are a lot of procedural fields. So, I mean, I'm just biased. I think I landed in the best one. But on my website, I give some advice. Like if you think you're too squeamish to do this, one of my most popular posts was called The Squeamish Medical Student. And so check that out.
All right. Thank you so much, Dr. Hamilton, for presenting for our web shadowers. We loved all the examples and images that you provided, and thank you for answering all of our questions. Everyone, make sure you check out her website, check out her Instagram. Her Instagram is at Tired Superheroine. The link to today's Google form has been posted in the chat box and will be in the description of the video shortly. Please make sure to fill it out within the next half hour for us to receive verification of your attendance. Thank you all for attending the session. We hope